do still work here. Shout out to Dr. Kendall and Gennaro for that. Today's topic is going to be about serial EKGs and others. So go ahead and jump into it. So just an outline of what we're going to cover. Just a little bit off topic considering today is kind of endo day, but we're going to talk about the utility of serial EKGs in the setting of possible ACS in the emergency department. And then kind of touch on some of the EKG findings that are not punch in your face STEMIs that you probably still should think about calling the cath lab for. And then finally, we'll again touch on how you might use this in your daily practice. So to start off with, we'll start with a little bit of a fake story that I made up. So it's a late 90 ED. It's time for you to start trying to clean up your patients, and all of a sudden you get a 60-year-old male who presents with persistent chest pain. He has a history of the classic triad of hypertension, diabetes, hyperlipidemia. You're kind of leaning towards an ACS type workup, and then you find out, of course, that the lab is unavailable because of so then you're presented with this quandary of how should you work with this patient in the absence of being able to send troponin. So you have two options. You can, one, wait for the lab to get themselves together, and also incur the wrath of the Dr. D'Souza, who will be upset with you for having waited not only for a troponin, but then having ordered troponin. Or, and this is relevant to this topic, you can get some serial EKGs and try to see if maybe this is a way you can roll out ACS. So just quickly talking about what serial EKG is, so we have a definition that we're all working off of. It's basically just EKGs done in series. They can be separated by days, hours, minutes. We all already kind of do this. If you look in a patient's chart and you're looking for an old EKG compared to the current one to, you are basically comparing serial EKGs. The point of this obviously is to assess for any interval changes. So a change from the old to the new is usually relevant and can be assigned a new ischemia. And the things that we often look for are any changes in the ST segments, so depressions, elevations, and then also the T waves, which can be inverted or otherwise, changed, which we will get to when we talk about some of these other EKGs that you should be worried about that are non-STEMI. All right. So just to kind of touch on again why this is important. So there have been lots of studies. One, this is a study from 1996 that actually showed that you can have patients who develop EKG findings that at the time, because they didn't have PCI, would push you towards doing thrombolytic therapy. And they said upwards of 20% of patients who were admitted for chest pain but initially did not have EKG findings that would merit thrombolytics then developed it over the course of their stay. And at the time in 1996, they advocated for the development of a protocol for inpatients with chest pain for serial EKGs so that they could do this. It never came to pass. I don't know of any serial EKG protocols that we do, but it was something they were thinking about then. And then, as you can kind of imagine, you can actually train pre-hospital providers. So paramedics actually with previous EKGs were shown to be significantly better at identifying STEMIs if they were given the patient's old EKG. So those are good to know. And in the more 21st century approach to it, there have been multiple studies now looking at whether or not we can turn computing power, information, to this problem and seeing if teach computers to find changes in EKGs that are otherwise subtle and not quite, again, super obvious senses. So just things to think about, and then we'll dive into this paper that I found. It is actually from Germany. It is by a doctor named Lehmacher. Shout out to FNF, Germans. The point of the study and the reason why I got interested in it was, again, from Dr. D'Souza, trying to find a way to join this crusade, not quite against troponins, but seeing if they're really as good as we think. And this was a paper that I thought initially was going to compare serial EKGs to troponins. The setup of the study was that any patient who presented to an emergency department got an EKG and the troponin at time 0 hours and then at 3 hours after that. Patients were stratified into 4 different groups based on their EKG findings. So over here, that's okay. On the far left, you'll see that a majority of the patients ended up in the group with no ischemic EKG signs. And for this study, they defined it very, very broadly as just any ST abnormalities or any T-wave conversions. They didn't really specify what kind of T-wave inversions, what ST abnormalities, but that was their definition. And then the three other groups were group number two, patients who had no initial ischemic signs and then developed them on the second EKG, and then the reverse for group three, so initial EKG signs and then resolved. And the last group was the group with ischemic signs on both of their EKGs. The important thing to keep in mind is all these patients, the only thing they have in common is that they presented for chest pain during the study period. So they did present good demographics, which I didn't include here. For the most part, they track to be the same in all ages for all above 60. Risk factors were usually about 1 to 2. So your hypertension, your diabetes, your hyperlipidemias. And then most tended to be male, like 60% of study participants were male. So they're generally similar. And what they ended up finding, not surprisingly, is that the most common findings were one, seen in the persistent ischemic group, as you can see all the way on the right-hand side, but also the most common finding is just T-wave inversions. So again, not super specific for anything, but this is the most common finding that they had. And after they stratified into their groups, what they found is there was this hazard ratio analysis that showed that, not surprisingly, patients with persistent ischemic signs were the ones most likely to have poor outcomes. These patients were followed from 30 days after their initial visit to 2 years past to find anything that they define as a composite endpoint. So either diagnosis of acute MI on a subsequent visit or being sent for catheterization for any given reason. Unfortunately, they don't define exactly what these reasons were or what follow-up was. But there is a significant difference, obviously, between the patients in the persistently ischemic arm and the other groups. The one thing that is worth pointing out, though, if we can go back here for a second, I forgot to point this out, is that the N of the last three groups is significantly smaller than in the non-ischemic groups. So a little bit hard to draw conclusions about whether changing ischemic signs, so the second and third groups, actually matters or not. But for sure, patients with persistent ischemic signs are at higher risk. And this is just the survival curve. They mentioned that there's 172 events over the course of the study period, and a statistically significant number of them occurred in the ischemic branch, or persistently ischemic branch, I should say. And so the limitation of the study, as we kind of mentioned, they didn't really compare head-to-head troponins EKGs. The only thing they used the troponins for was for a retrospective analysis done by two cardiologists to decide if the initial visit qualified as ST elevation MI, at which point those patients were excluded from the study. It's kind of unfortunate because they had a perfect setup to compare troponins EKGs, but didn't choose to do that. And then again, as we mentioned, there are relatively few patients outside of the persistently non-ischemic branch, so it is a little hard to draw conclusions. And the last thing is, this study was really looking at long-term mortality for patients after this initial ED visit. So any events that occurred within the first 30 days after the sentinel visit were actually just chalked up as being related to the initial visit. So those patients actually were thrown out of the analysis. So there's limited applicability for us, even though this study was performed out. So that kind of brings us to the next half of this talk, which is going to be just quickly running through some EKGs that are worth knowing. These are all the quote-unquote non-STEMI or STEMI equivalents, which if you read some of the online blog post stuff is kind of a misnomer, because what we're really looking for is evidence-inclusive myocardial infarction. And so we'll touch base quickly on each of these, talk about where they tend to point to an ischemic event occurring, and why you don't see the, or at least why it won't be an ST elevation. All of these have been shown in different studies to be relatively associated with occlusion on cath. So there is evidence that if you see any of these, it is at least worth calling cardiology to see if they want to cath this patient, especially in the setting of active chest. So we'll start with posterior MI. This one, I think, for me at least, makes the most sense. You have an infarct in the back part of your heart, and so instead of ST elevations, you just see ST depressions. The classic finding is just diffuse horizontal ST depression, so you should see them in precordial leads. And if you do a posterior EKG, you'll see your classic ST elevations. I didn't include an EKG for that, I probably should have, but sorry. Things I think about at 9:05 during this talk, in any case. So that is one. Yes, Dr. G.
I just want to point out, though, there on this one, there's also inferior wall.
Correct.
So you have your ST elevations there, and there's probably an inferior lateral as well, because you also have some elevations coming up in V6. So even if you didn't see the depressions in V1, V2 with the relatively large QRSs in V1 and V2, and then realize that's occlusive, in this particular EKG, you should realize the other leads. So,
correct. So Dr. G is just pointing out that I have picked an EKG that demonstrates not only signs of posterior wall MI, there's also signs of lateral, and there's also signs of inferior wall MI, as noted by the ST elevation 2, 3 AVF, the elevations in 5 and 6. So, thank you, Dr. G. But yes, posterior MI, keep an eye for that. Next up on this little journey through ischemic attacks is the De Winter STT wave. So this one also, I think most of us are pretty familiar with. You're just going to have mostly it's tall T waves in the precordial leads, so you can see them in V1 through, this would be V1 through V4 here. There should be an absence of ST elevations in this one. And again, this one is something to keep an eye on. It's usually a sign of anterior occlusive MI. Next up are T-wave inversions in AVL. So this one is a little bit more controversial. It is definitely associated with left anterior descending occlusions, but the specificity is quite high, though the sensitivity is quite low. If you kind of imagine just having an isolated T-wave inversion one lead, wouldn't really be that sensitive for finding this. You usually have other findings, but it is something that on CAT they have found to be actually pretty specific. Usually the CATs are done for other reasons, or at least with other findings, but something to keep an eye out for. Wellens is another one I think we're all quite familiar with. So in this case, you can have either the A-type or the B-type, so either the biphasic T wave in V2, V3, or you can have a inverted T wave in the type B in V2 or V3. The one caution here, this is one of the two that you can actually have pseudonormalization. So if a patient had a previous with Wellman sign and then develops ischemia in the left anterior descending, they actually have what look like normal T waves on their EKGs in V2, V3. So it is something to keep an eye out for. It's one situation where having a previous EKG can be very helpful, especially again in the right setting for chest pain. So this one, this is right bundle blanch block with left anterior particular. This one is a little bit hard for me to take out. I actually ended up on Dr. Smith's EKG blog trying to find the definition for this. I think we can all look at this grossly and just say it looks bad. So this would not be someone you would just send home, obviously. But the actual breakdowns of what are make this right bundle blanch with left anterior particular are a little bit hard to pick out. So I will just throw out his annotations here, which are super helpful. But the takeaways are there's a wider QRS, which is quite obvious. All of these are actually preceded by P waves, so that actually takes it out of the realm of being V-fit. There is a left axis deviation, and you have ST segment elevations in V2 through V4. So, this one is a little bit more complex. Again, I don't want to spend too much time on it. I think we all just kind of need to spend time. It's just a lot of pattern recognition. But this is certainly something that I think most of us would at least look at and be like, bad news. So keep that in mind. Yes, Dr. G.
One of the giveaways here, I think, and this is, you look at it and it's bad and you get help. But like you pointed out over there, the other thing is with a right bundle branch block, right, in lead one, in a right bundle, you should have a big S wave, right, as reciprocal to having a right bundle, which you have here. When you look at lead one over there, you see there's no S, and instead you get ST elevation, right? It should go down and then come up, but it doesn't. And that's, I think, the clue in this one, that there is an infarct involving in some anterior leads, not just the right bundle leads. And then the other thing that would bother me a lot is in V6 also, where you see again that elevation, right? Because even though it's a right bundle and not a left bundle, you can still follow those rules. It should go down, and then the ST elevation should be opposite, just by having a bundle. But instead, you have elevation there before you go down. So to me, that does look like an MI in those two leads, in 1 and in V6, and an L. Those three.
All right. And then I think this is the last one. Oh, no, I thought this is the second last one. Hyperacute T waves. Sorry, I'm almost done, I promise. So this one is literally just tall T waves, classically associated with hyperkalemia, and the suggestion is always to follow this with either a shock or a pump, make sure that that's not the cause. And this is the other one to keep an eye out for as far as if a patient is having acute ischemia. A patient can go from having hyperacute T waves to then, after they develop ischemia, either having normal-looking T waves after spontaneous reperfusion, or they can actually go the other direction and then go from this into developing actual ST elevation MIs. So it is something to keep an eye out for. This is actually a wonderful example of a pattern that would be great to do with serial ECG. And then the last one is left main coronary artery occlusion. This is a very, very proximal occlusion of your left main coronary artery. What you see kind of makes sense. You have diffuse ST depressions as well as ST elevations in AVR. So if you cut off blood flow from the left main part, you get kind of global ischemia. These are basically depressions and elevations just reflect that.
So this is like a really, sometimes you just get the AVR and none of the depression.
Correct, yeah. So the actual definition is just an ST elevation AVR greater than 1 millimeter with an ST elevation AVR greater than V1, AVR greater than V1. But yes, this one has a lot more other stuff than just that. Correct.
Yeah, and we always talk about a pattern and following 2, 3, and F, or 1 and L and V5, V6. But the two leads that can be very tricky by themselves are AVR, if you see elevation, and L, if you see an L, even an inverted T wave or something by itself. Because those leads, unless you're used specially, you might not see. But if you did a lot of lateral, then you might see more than just L, for example, with posterior MI.
And so Dr. Yu is pointing out, keep an eye on AVR and AVL. Those ones can alone be indicative of either far lateral or far medial wall infarcts. Okay, and so just kind of touching again on the importance of these non-ST elevation, quote unquote, findings. There was a study actually done by this person, Evidencebased, I don't really German, sorry, Annette, where they did PCI on patients with acute MIs and who were found to have left main coronary artery occlusion. And they actually found that out of those, the patients with right bundle branch block in the setting of usually left anterior testicular block, 9 out of the 35 patients with left main coronary occlusion had that EKG pattern. So it is, as you can see on their cool little pie chart here, after ST elevations, it is the next most significant EKG finding for those patients having a pretty significant obstruction. Right. And so we've reached the end, I promise. Putting it all together, basically, assessing ACS, there have been multiple studies that show you can't really pull one thing out and use that as your defining tool. So I apologize to Dr. Souza for that. EKGs, troponins, and your gestalts all together are actually what provide you with the best chance of properly diagnosing ACS, which kind of makes sense. More data allows you to be more accurate. The one thing that Dr. Souza did ask me to point out is in this EKG stroke argument, a troponin does take time. So you have to draw it, or the nurse has to draw it, has to get sent to the lab, has to take, about an hour or so to get it done. At which point, your patient could have infarcted more of their heart, whereas an EKG can be done instantaneously at the bedside, and you can actually repeat it multiple times while you're waiting for your stroke to be done. No.
Just because you're invoking Dr. D'Souza, I imagine he'd want you to say, just give them clopidogrel, Lovenox, and send them to Bellevue or MIMO, and not to wait for cardiology to come and see them and get them out for their definitive treatment.
So for those who didn't hear, Noah was just invoking that was pointing out that if I'm going to invoke D'Souza, he would point out that not involve cardiology here and then get them to a CAT center. But I'll leave that for Dr. Souza to iterate on his own. Yes, Dr.
Just 2 quick comments. So I like very much, a lot of it has to be your clinical gestalt. For example, if they're still having chest pain and you're impressed, the EKG is not diagnostic, you can repeat that EKG in 5-10 minutes. In fact, the American Heart Association says that for ongoing chest pain, you should not wait that usual 6 hours that often we will wait with our second set of enzymes, but you can do that right away. The other thing sometimes is you also pointed out, getting an old EKG. And unlikely, but I've seen it a couple times, is what's called pseudo-normalization. You have someone that has an EKG that looks okay, but they're having significant chest pain and they have risk factors. And then you get an old EKG and said before they had T-wave inversions and now they're upright. And you say, wow, there's a change. So both repeating the EKG right away after having ongoing chest pain or getting an old EKG, even if the EKG you have doesn't look too bad, and seeing if there's something new in it.
Okay.
Awesome.
All right. And then the last point here is just being aware of those EKG patterns we talked about. Again, these quote unquote non-ST elevation MI things, or, if you're in the blogosphere of emergency medicine, inclusive MI is OMI. Which then leads to the last part of this, which is just a plug for, by our own Charles Murchison. There was a great blog post on the Kings County blog about whether or not we should pause these patients. The takeaway, no, but I'll let you read that. And then, as mentioned, the OMI manifesto by Dr. Smith. So that one also is quite good to read about. So I just want to give some thanks again, Dr. D'Souza, for pointing me down this rabbit hole and trying to join this crusade. It's been educational, to say the least. And then the EKG Grads Farm team, who put up with me very much delaying putting this together because I just used the excuse of being on sick here. So Dr. Tankar Subini and Dr. Padawala. And then lastly, my wife, for just walking behind me for the last month every time I was in the theater and being like, "You're still not done?" And I was like, "Yeah, I'm not." So that was super cool. So shout out to her. And that's it. Any questions?
Very good.